Let's welcome our next speaker, Dr. Veera Suwanruangsri from Thailand. His topic is endovascular correction of dialysis SS syndrome.
Good afternoon, Chairman, ladies and gentlemen. I would like to talk about endovascular correction of dialysis excess steel syndrome. Dialysis excess steel syndrome was first described in 1969, and the incidence allowed 1 to 2% for risk AV fistula and between 4 to 8% with brachial bed excess. And the risk factors were diabetes, PAD, CAD, brachial bed excess, female gender, history of dialysis excess steel syndrome, and multiple previous excess procedures. Indication of treatment were grade 2 intermittent ischemia during dialysis and grade 3 ischemic leg pain or tissue loss. There were two basic strategies for the treatment of dialysis excess steel syndrome. The first strategy was excess flow reduction. We have three options: banding procedure, revision using distal inflow or Ludi procedure, and ligation of the excess was the last option. And another strategy was augmentation of distal arterial flow. We have three options: proximalization of arterial inflow, distal revascularization, interval ligation, or dual procedure. And the last option was distal radial artery ligation. For endovascular treatment option, before perform PTA, we should perform angiography, include imaging from aortic arch to the hand. And we can perform inflow angioplasty if we can see inflow stenosis, or outflow angioplasty, what the most common procedure if we can see outflow stenosis or occlusion. Or sometimes we can perform inflow and outflow angioplasty. And the last option was coil embolization of radial artery. And then I would like to show you for our case. 55-year-old female present with CKD and risk factor were diabetes and hypertension. We performed left brachiocephalic AV fistula 1 year ago, and clinical presentation were leg pain and tissue loss. This slide, you can see angiography. We advance the wire and the sheath through basilic vein to anastomosis and perform angiography. And you can see severe stenosis and occlusion of ulnar artery and minimal blood flow to the finger. And after we perform PTA with 2.5 millimeter balloon, you can see the conviction was perforation. And the final result show good flow to radial and ulnar artery and good flow to the palmar arch, improved blood flow to the finger. After we perform PTA of left forearm at 2 week follow-up, the clinical improved, no arm pain. Another case, 63-year-old male present with CKD and risk factor were diabetes, hypertension, and CAD. We performed light transport brachiobasilic AV fistula 10 months ago, and clinical presentation was leg pain. Angiography, you can see stenosis of radial and ulnar artery. We advance the wire and the micro catheter into radial artery and perform PTA with 2.5 millimeter balloon. And the result is okay, good flow to radial artery. But you can see the palmar arch is not complete. And then we advance the wire and micro catheter into ulnar artery. And you can see the right picture, good outflow. And angiography, you can see good flow to radial and ulnar artery. But for the right picture, you can see dissection and recoil of distal ulnar artery. And the final result, good flow to radial and ulnar artery. The right picture show, you can see for this case, we try to advance the wire to make the palmar loop, but we cannot succeed. And the final result is not perfect. At 7-month follow-up, clinical improved, no arm pain. And the last case that I would like to show you 78-year-old female present with CKD and risk factor was hypertension. We performed light brachiocephalic AV fistula 1 year ago and performed PTA of right forearm because of still 6 months ago. And clinical presentation was less pain and tissue loss. And we decided to perform surgical correction. We perform proximalization of arterial inflow, but the clinical not improved. And we decided to perform PTA again. Angiography, you can see good flow to radial artery, but for ulnar artery, you can see recoil and reocclusion. And then we advance the Y and use a scoring balloon, angioscope balloon 2.5 millimeter to perform angioplasty. And we try to advance the Y to make the palmar loop, but we cannot succeed. You can see perforation. And then we advance the Y to radial artery to make the loop, perform palmar loop angioplasty. And the final result, you can see good flow to radial and ulnar artery, good flow to the palmar loop, and improved blood flow to the finger. After we perform repeated PTA of right forearm with scoring balloon, unfortunately for this case, the clinical not improved, and we decided to perform AV fistula ligation. And after ligation, the clinical improved, no arm pain, improved wound healing. For our small experience in 2 years, we performed endovascular collection for dialysis excess steel syndrome in 5 patients, and risk factors were diabetes and hypertension. On 5 patients, we performed brachial artery-based AV fistula, and the result of endovascular treatment, clinical improvement in 4 patients and not improved in 1 patient, and we have to perform AV fistula ligation because of no clinical improvement after PTA and PAI procedure. And this slide shows the reported of small case series of 6 patients in 5 years with mean age 62 years, and risk factors were diabetes, embolization of distal radial artery, and angioplasty of proximal artery stenosis were performed in all 6 patients, and symptomatic recovery was observed in all patients. And look at this slide, the left picture, you can see minimal blood flow to the finger before embolization of distal radial artery compared with the right picture. After embolization of radial artery, you can see improved blood flow to the finger. And this slide shows the conclusion of our clinical practice. When the patient presents with dialysis excess steel syndrome, we perform complete angiography. If no inflow or outflow stenosis, we choose surgical correction. If not improved, ligation was the last option. And if presentation of inflow or outflow stenosis, we choose PTA procedure. If not improved, we try again with surgical correction. If not improved, ligation was the last option. Thank you for your attention.